insight and inspiration, and I'm just thrilled to introduce you to Director Nicole Alexander-Scott. Nicole is a wonderful asset to our public health family and someone I've really enjoyed getting to know over my years at ASTHO. And I was reflecting back, Nicole, you were actually, I think, on the search committee that hired me. I think that's when we probably first met. And it's just been so fun to work with you since that time. Just in terms of quick bio, Nicole Alexander-Scott has been the director of the Rhode Island Department of Health since April of 2015. She brings a tremendous experience to this position from her work as a specialist in infectious disease for children and adults, as well as her time in academia as an associate professor of pediatrics, medicine, and public health. She is board certified in 4 specialties: pediatrics, internal medicine, pediatric infectious disease, and adult infectious disease. And I'm really pleased to say she was also president of ASTHO from 2018 to 2019. And that's where she pushed us as ASTHO and her colleagues across the country to focus on what's now the ASTHO challenge to build healthy and resilient communities. And since she joined the department in Rhode Island, she's really focused on giving every person and every community in Rhode Island equal opportunity to be as healthy as possible. And they've done some pretty innovative work in the state, really touching on some of the material that Tony Eiten shared with us last session we had for Insight and Inspiration around zip code and health equity in communities. And it's been fun to take that challenge and not make it national and see how other states have seized it and moved it forward. She's originally from Brooklyn, New York, and she attended Cornell University and subsequently graduated from medical school from SUNY Upstate Medical University at Syracuse, completed a combined internal medicine and pediatrics residency at SUNY Stony Brook, and finished her fellowship at Brown, which I'm thinking is probably what brought you to Rhode Island. Maybe we can hear that story, where she also got a master's in public health. So what an esteemed colleague and one of just a wonderful resource to us all. Thank you for being with us for some insight and inspiration.
Thank you, Michael. Such an honor to even be asked and be able to spend some quality time together.
Thank you. And we appreciate all you and your colleagues are doing in Rhode Island and the thinking you're providing nationally. I know many states have looked to you for advice and information, and you've done the same. It's part of the ASTHO response to COVID. So we'll get into that a little bit, but I thought maybe we could start just getting to know a little bit about you. What a biography, and what brought you to Rhode Island?
Yeah, it was what you said. After finishing residency in New York, basically doing all of my previous education in New York, I came to Brown to do the combined adult infectious disease and pediatric infectious disease fellowship at Brown, which spanned out over 4 years. And then was blessed with the opportunity to stay on as faculty in adult and pediatric infectious disease divisions, teaching, associate program director for the Peds ID Fellowship over time, and working with the medical school. But then also that was the year of H1N1. And the Department of Health was asking for a subject matter expert. And my fellowship program director offered me as the individual that would just be part of your rotation, that's it. And I never looked back. I finished fellowship, but it led to being offered consultant medical director position at the Department of Health. And I had also applied for and been accepted into a research training grant that supported me in getting a master's of public health at Brown. So was able to do all three at the same
Yeah.
time. Hardest
Wow.
2 years of my life. Since 2011, I worked both at the department as well as academic faculty at Brown until I was offered this role by the governor in 2015. So
Wow. Wow.
it's been an honor.
That's great. What a journey. It's always interesting to see how people end up working in governmental
Mhm.
public health because, not everybody even knows what the health department does until they
Mhm.
stumble across it. But I think given COVID, everybody's going to know a lot more about what public health does and what governmental public
Hopefully,
health does, hopefully, for
be
sure.
able to
But you're
resources.
quadruple boarded. Like, help me understand how that works. How are there enough hours in the day to do that?
Yeah, you take it one day at a time. I think that's been some of the best preparation for this marathon of sprints is knowing that I did med peds residency. So that combined internal medicine and a pediatric residency, each of which are 3 years. That 6 years combines into 4. And then I did an adult infectious disease fellowship, which is usually 2 years, and a pediatric infectious disease fellowship, which is usually 3 years, and combine that into 4 as well. And I've loved it, because my major in college was human development and family studies. I've always been interested in the spectrum of life from the very young to the very old.
Mhm.
And infectious disease is one where there's a lot of overlap between both populations, and I've often referred to it as being an Inspector Gadget of sorts. You have to be inquisitive and understand. So where did you live, and did you have a basement apartment, or was it upstairs? And what type of exposures have you had, and the food that you ate? All of that contributed to what type of infection or outcome someone had. And a lot of that has paid off. And I was thankful too to see the connection to public health. That wasn't planned at the beginning. I actually hoped that I would get a master's in business administration
Oh my.
because I knew that having that financial understanding was critical, as a clinician. But during my first year in fellowship on the pediatric infectious disease side, we had an infant who was born to an undocumented teenager. And true to the history, those in the clinical setting, on a Friday evening at 5, we got the call that the blood work that had been sent on the infants from the emergency room returned positive for HIV. And it had been sent because the nurse who was drawing blood on the infant as part of a normal fever workup had been stuck by mistake. And the blood pathogens workup that you do includes testing for HIV and other organisms that are transmitted by blood. And so we learned that this 4-week-old baby was HIV positive, and that her mom had not been given really the opportunity to have prevented transmission during pregnancy, because at that time there were very known interventions you could make. And I recognized that during residency, I rarely saw anyone born with HIV because of all the interventions that were in place, and the laws and policies in Rhode Island did not make it conducive for that to happen. So there were more babies being born here, and that motivated me to understand how we could change the law and policies and make it better at a population level. And I learned quickly there are just 2 degrees of separation here in Rhode Island compared to other places. So literally 2 people later, we were talking to the legislators that sponsored the bill that we advocated for and ultimately got passed. to require verbal consent instead of written consent for HIV testing among pregnant women.
Wow.
And from that point on, we were able to go back and change HIV testing consents across the board in all healthcare settings. And within a few years, we had no further infants born with HIV because of that. And it changed my life in terms of the understanding of impact you could have from a public health perspective. So never looked back since then.
Right. Wow. That's really a great sort of, I wanted to follow up to that because I was going to ask, you've done so much clinically and training with all those specialties, and now you're sitting in an office. I visited your office. There's no clinical rooms in your health department. There's offices and cubicle areas and meeting rooms. What is that like to now have your patient be the state, not an individual, that you're caring for in an exam room or in a clinic?
Yeah.
Is that where you got that insight into what the public health policy world is like?
Yeah, it started with that story because I spent more time in the state house, learning and understanding what the exposures were. Growing up in New York City, I still haven't been to the Albany State House, but being here in Providence, I'd been here, been to the State House tens of, many times, however many that would be. So that exposure was very helpful. And then the years where I did both, serving as faculty in adult and pediatric infectious disease, seeing patients and teaching, while also being a consultant medical director at the health department, really gave me that lens for understanding the value in both worlds. There's absolute necessity for having that one-on-one individual care. I still miss my patients on the adult and pediatric side, and I'm always honored when I get a quick call or get bombarded by someone out in the community. And the impact that you can have on at a one-on-one level is important. I think often that one of my patients made their baby daughter's middle name Nicole, which was like the ultimate gift. And balance that with the public health realm. My computer cut out, so I will come back on.
No problem.
Where you can, have the population level impact. And it also helped me appreciate the frustrations on each side. The folks in the public health world would say, those clinicians are overreacting. There were 3 cases, even though it was an acute HIV, it was 3 of them. There's a whole population of people. Tell them to calm down. And then the clinicians would say, those public health people are going too slow. Why don't they get the importance of this? Sound the alarm. Right. And seeing how necessary it was to have checks and balances and thoughtfulness on the population side, because you're making decisions that are going to impact thousands, and in Rhode Island, 1 million people, while also being able to have an individual approach that impacts an individual's life in your hands, firsthand. So that appreciation for both realms was very helpful in preparing for taking on this role. So I did less of the head banging against the wall that you see clinicians coming into the public health realm experience, really like, it's too bureaucratic. There's a balance to it. We can still get things done. You can have a tremendous impact, and need to leverage all lens and perspectives that you have to make it work.
Yeah, it's fun to watch folks blend that clinical and community perspective and take a population health approach, which is where I think all of public health is going, and then healthcare is going too, for lots of different reasons. But I wanted to ask you a question that actually came in from our chat while we were talking, which was, do you think your infectious disease training has helped you better manage COVID-19 in Rhode Island? And how so?
For one, it gives you credibility. There's nothing like being able to say, that you are with the same specialty that Dr. Fauci is from, and say how awesome infectious disease doctors are, and we're always on the front lines of emerging and new challenges from an infectious disease perspective. And then it also helps you really be inquisitive. You know, I mentioned earlier, it's usually, I've been told, you know, in the clinical realm, oftentimes when people have charts that are this thick in, you know, the hospital, the clinicians will go through and look for the infectious disease consult, because that's where they'll get the most comprehensive story and all the different dynamics and the full picture of what's going on, because you need that in order to provide the best guidance. And so that skill set, I believe, comes in handy here, where we have to understand, so what are the implications with the type of testing modality and the rate of transmission that occurs, and how that interfaces with the specific populations that we're concerned about, really putting that whole picture together to help determine your path forward is a skill set that I'm familiar with and always needs improvement and refining. So yeah, it's definitely a path that I've enjoyed and appreciated.
That's excellent. Well, in our series, I was reflecting on this with you when we were doing our prep call last week. You're the first health officer we've had, which is funny for ASTHO, but we've wanted to pull from lots of different parts of the world to get insight and inspiration. But because you're the first health officer we've had on, and the fourth in our lineup of 5, tell us what's going on in health departments right now. Like, what's the vibe? I mean, I get to talk to health officials nationally. I've seen the roller coaster of ups and downs from leader level folks. But tell us sort of what's your sense of what's going on either in your health department or your colleague, your friends, your neighbors, just what's going on in public health right now. There's just so much.
Yeah. I have called this the stretch of a lifetime, indeed. At baseline, prior to COVID, there are components of this role as a health official that makes it a privilege, and that also captures scenarios that you just can't make up. You know, you couldn't imagine that some of the things happen, and it requires this tug in being able to balance, particularly as a state health official, the engagement with your governor and that office and all of the components that are in place with the leaders within your agency, and being the leader for that agency, however big or small it is. With Rhode Island, we are blessed in a sense that we are one public health department, so we are the state and local entity performing both duties. So COVID took that baseline and just stretched it in ways that really test your resilience, your strength, your ability to encourage yourself and be able to pick up and keep going. So our governor, to her credit, she's brilliant and thoughtful and aggressive, and so recognized upfront that public health had to be front and center in responding to this pandemic. And so there is this whole new dynamic of media and exposure and public-facing leadership that has been helpful, because it's such a critical piece to a strong public health response, providing timely, accurate information to the public. So I've been grateful for that opportunity and done my best to step into that component of the role as best as possible. At the same time, we're needing to figure out how to balance our role as the centerpiece of a public health response. It's an infectious disease. We're used to activating our incident command system and running it, while knowing now that this requires, the term we've been using is a whole of government response. It cannot be just us the way it has been in the past, even for H1N1. Everyone just relied on us. Here we have, you know, an unbelievable partnership and connection to the National Guard. The general of that National Guard has become my battle buddy, as we've referred to each other, as so many more connections with the Secretary of Commerce, across all of government, certainly our education commissioner, and everyone has had to join in contributing to this response. I've chuckled a few times because the governor has said, you know, before COVID, we didn't know what contact tracing was. And then I look at her and she's like, well, she knew, but none of us knew what that was. Right. And now everyone has to, you know, become some type of public health expert, and navigating that can naturally, you know, be a challenge, and it really tests your ability to adapt and respond. We've had to go with it when it's all right. It's not just the department, it's all of us. And how do we, you know, get that help while also, you know, partner better with the whole team. So that has been a journey. And then doing all of that at the state level and local level for us within the landscape of the national perspective that, again, are stories that you can't make up. But it has been frustrating to oftentimes have the feeling, I've described it a few times, where you're in a battle and the people who should be on your team are like banging out your legs to try to take you out at the same time. Right. So attempts to get PPE, testing supplies, protocols on what we could be doing so that there is leadership and a unity, as opposed to states doing one-offs and second guessing each other and starting from scratch. That's been a little heartbreaking for me. But we are in the scenario that we're in, and I'm grateful for a family such as ASTHO that, in spite of that, can help us come together and figure out how we can learn from each other in real time while still being busy, because we have to respond to everything in our own state. And try to help us move in one direction, particularly when the leadership to do that at this highest level is missing. I've definitely appreciated some of the federal partners that we know as individuals and how much of their heart is in it. Certainly our esteemed Surgeon General, Dr. Adams is a perfect example. We've also communicated multiple times with our Assistant Secretary of Health, Admiral, Ambassador as well, Deborah Birx, individuals who you know are doing the best they can, but you certainly wish that there was more of a coordinated leadership approach that would help us be more effective as a country, rather than so many of these one-offs and additional layers of challenges in the once-in-a-lifetime pandemic. Right.
I wanted to ask you, because New England has a history of doing a lot together, you know, how are you guys coordinating that regionally? You know, usually if you do something, Massachusetts and Connecticut have to do it. If they do something, you have to do it. It's just because people go back and forth and so frequently. What is that like?
It's one of the more humbling pieces of this, because I've said many times how much I miss my ASTHO family. We would do well, usually as a region, coming together on a weekly basis. We've all been challenged with doing that consistently, because everyone's getting pulled and something has to give somewhere. So we do the best we can as a region. We're oftentimes having one-off conversations with each other to do our best to keep up. We oftentimes do have our governors reminding us of what each other is doing, and make attempts to stay aligned in one way or another, either beforehand, before a decision is made, or after a decision is made. And I think by and large, as a result, we are aligned as a region, and certainly we're all on board with mandating, mask wearing and many of the core requirements that are needed. But it would be so much more valuable if we could, so what are you doing with this element of K through 12, and how are we handling that? So we're just going to keep pushing and doing what we can to keep coming together, because it is critical. It's so critical to help learn from each other and bounce off ideas from each other.
Great. Well, one thing I know you've really let in is the health equity zone idea, the concepts. It's really a marquee program for Rhode Island and your team. And it's one that you've shared with the nation. What I'd like to do is just pivot to that, because it's so important. And then we're getting some questions, so I want to save some time for those too. But I didn't want to pause without mentioning the health equity zone. And tell us the story of that, and if you can, how did that work in COVID? How is that infrastructure, the health equity zone system, been pivoting to COVID?
Yeah. So the genesis of the health equity zones initiative stemmed from the fact that year after year, time after time, we know data on disparities that exist. Higher rates of overdoses, higher rates of sexually transmitted diseases, higher rates of domestic violence, or poor educational outcomes, or housing instability among communities of color. That was again repeated with COVID, higher rates of that among communities of color. And it's recognizing that there is not something genetically or physically different about communities of color that just happen to result in these rates being higher, regardless of the majority of disease or other conditions you look at. It forces you, when you really want to understand that the social and economic and environmental conditions that those communities are subject to more often compared to others contribute to why we see this again and again, city after city, state after state. And the Health Equity Zones initiative is intended to shift from talking about it. Like, I don't want to do another data analysis and survey to determine, are there disparities, and understand why. We know the disparities exist. We know why. Health Equity Zones is designed to, let's do something about it. That's the real push for me. I don't want to talk about it anymore. I don't want to study it anymore or survey it anymore. I want to put deliberate resources in a structured, data-driven way into communities that we know haven't had the voice to address what they need to for themselves, and do need that level of support and investment, so that communities can drive the systems level change, policy level change, economic resilience that's needed to shift the fact that right now, the zip code that you're from determines how healthy you are, how long you live, what your outcomes are. And that's designed. It's acknowledging the fact that it's designed. I've been repeating the mayor of Stockton, California's saying, who he got from someplace else, upset the setup. It's understanding that there was a setup. Many of the urban communities that are disproportionately affected didn't just coincidentally happen that way. There's a composite of cumulative policies, institutions, discriminatory factors that were put in place to cause that. And the only way that's going to be fixed if we are deliberate and intentional about investing resources at that community level, empowering the community to drive the change and push on the change and stop circulating around, well, what does the data show and what does the survey? So health equity zones are geographically self-defined areas across Rhode Island based on what the community determines. It has to be a population of at least 5,000 or more, and known disparities that exist in that community, with investments that as a department, we braided funding from our federal partners, from foundations, from private funding, from the state, and gave it to the community through that health equity zone in a unified investment, with them required to put together a collaborative, use their data and assessments to determine what action plans need to be done, and then use the investments that they receive to drive change. So that's improve determinants of health, really, is what the focus is. And really get at the structural root causes of what contributed to those communities being where they are, and then ultimately work towards sustaining those resources, figure out ways to bring in more investments. So we started with 15 health equity zones. We now are into our second cohort. Some have faded but continued to work in different ways. Others have been added. We have 10. Each of the ones that continued were able to apply for and get additional resources and investments. And our focus is continuing to bring in resources that will allow us to expand so that every city and town that wants to is able to have that type of ready-made infrastructure to invest in and know that you're going to get return on investment that's data-driven and get to outcomes, and have it continuously be evaluated so that those improvements can be seen. And it's improvements not only in health outcomes, but in living conditions and in policies and systems. So that's been a vision, and it's connected with our ASTHO challenge of building healthy and resilient communities, recognizing that the first goal is to put together infrastructures that allow the community's voice to be at the forefront and to drive sustained change using models like health equity zones. There are many others, purpose-built communities in Georgia, Fort Worth, Blue Zones, Live Well, San Diego, and then also help provide unique and out of the ordinary ways to push investments into those communities. I always appreciated the Surgeon General's focus on community health and the economy, and helping businesses in communities understand that it improves their own business bottom line when they invest in the surrounding community. And then here's the ready-made infrastructure to invest in. So it's not in silos, but we can actually bring that together and drive collective action that will last for the long term. That's been the vision and the heart for health equity zones.
Yeah, and there's a growing body of knowledge on how it works and what works. You know, as you mentioned, there's other projects across the country too. But for folks who want more on that, you've got some stuff on the Rhode Island Department of Health website, and we have some stuff on our ASTHO.org website. So it's been an amazing project to watch grow, and there's so much interest. I just thank you for that. Someone asked, what do you hope your legacy will be as a state health official, and I think it's related to what we were just talking about, but I'm making an assumption.
Mhm. It's one of many, but it's actually driving sustained change and improvement that we know is needed. And it's a full-time job, really, to try to get, you know, investments from here or ideas from there, and to push them together in a way that the community can really push forward on what improvements are needed. The health equity zones during COVID, for example, allowed us to have a head start when we knew that communities of color were being disproportionately impacted. Not a surprise, because it's yet another disease entity or condition that is occurring because of those underlying structural root causes that contribute to the disparities. We didn't have to start from scratch with establishing a relationship with the community, making sure that we're understanding what they're saying. That work still had to be done, but we had the HES infrastructure to build on and to use to get funding out to the community. And it still took longer than I wanted to, but we already had the funding mechanism in place. Encourage the HESs, keep looking and seeing who's in your community that needs to be supported. And we push funding out to them so that they can get it out to others, hand out masks, make sure that quarantine and isolation supports are in place, make sure that information about testing and standing up testing sites are in place, so that we have the most testing being done in our communities of color. That is an example that's done because of that HES infrastructure. So I would want those resources, that strength, that platform to grow, you know, and to be sustained in a way that changes the outcomes of communities that year after year, again and again, go through the same disparities, the same challenges. The schools are the same, the lack of grocery store access and fresh fruits and vegetables are the same, the poor housing is the same. We have to change that and move from, oh, so what does the data show and why does it happen? We know it. Let's invest and actually push action and changing that, because it's time. Children are impacted generation after generation in a way that it doesn't need to be. And we have to empower ourselves and the community to force that improvement and make it be sustained.
Right. That is inspiration right there for sure, and legacy. We have a question here. How do you triage priorities when everything can feel like a priority? And at the same time, how do you take care of you?
Hmm. Hmm. Well, for the triaging priorities, you know, so much of the stretch during this journey is exposing the importance, but balance, of staying humble. You know, you have to be responsive to what's happening and what adjustments you need to make, and what's driving the most important need right now. And certainly what our priority was early on in COVID has evolved to what's important now. So being able to adapt and being surrounded by leaders with you that can either push you or support you in that flexibility and consistency in leadership and strength is critical to helping prioritize. So, you know, making sure that I have someone with me that understands what's needed to operationalize. We can come up with the vision and the policy and the strategy behind it. We need that whole of government response to operationalize it, you know, effectively, and measure the outcomes, and help refine where we need to because of logistics. So having that team around and staying humble and adaptable, to me, is the key to prioritizing. And then for myself, which is where I feel like the medical background helped, because the number of years of education and training, if I would have known at the beginning that it would be never ending, you kind of give up. But you just kind of go for the journey one step at a time. And so I've applied that to this, the importance of cherishing the moments. I'm so grateful for my husband. I have a particular affinity for Michael's,
Great
as
name.
you can imagine. And he's certainly the secret to my success, in helping to support me while reminding me of what's important. And then just appreciating the miracle of my now 16-month-old Christian Michael, who just thinks it's normal that mom's talking on the phone till 8, 9 o'clock at night, and he gets to hang out and, cuddle with me during that time. And, there's nothing like counting your blessings that this pandemic has really exposed. And I had always kind of sensed that. I'm a person who lost my father when I was 11 years old. And when you look at some of the studies, it kind of changes something in you as an individual, where you have a particular appreciation that you don't take for granted, because you know how things can change so quickly. That has probably continued with me through my life. My mother also lost her mom when she was 11. So having that understanding definitely helps, that when it's challenging, that there's someone who's going through even more challenges that you can reach out to and help. And that also builds you up at the same time. So appreciating those moments through this. I'm known to be on one of those late calls and be out in the park at the same time with my guys, getting some fresh air and walking by the water or something along those lines, so that when we fit that balance in. It's been one of the challenges because I'm so connected to family, and have been in withdrawals of not being able to have that personal, in-person connection. But certainly between faith and video and phone, continuing to push myself and valuing the family and the loved ones that I am so grateful for has been key to a balance for me as well.
Right. Well, we didn't talk about resilience, but you just defined it, and you demonstrated it, and you gave us a use case for it, and you really, I think, spoke to what I know I'm going through and lots of other people are, in terms of connection and resilience. And the term I've learned over the last few months has been post-traumatic growth. How do we take a real bad situation and learn from it, and then how do we look at how we survived it and then use that to appreciate ourselves, and then bring us to the next level of performance and engagement, which I think is an unintended positive consequence of all of this, hopefully, for many of us.
Indeed.
Well, the insights you've shared and have been inspiring. You have done amazing work on Rhode Island and inspired colleagues similarly. Thank you for spending just 45 minutes, which just felt so refreshing and good to talk with you and hear from you. And I hope everyone agrees with me on that one. I'm sure they do. Any last thoughts before we sign off?
I so appreciate this opportunity, and miss the connection with everyone across the board, but want to still hold ourselves up in encouraging that we keep doing our best to stay connected in whatever way we can, even if it's in a new way, and figure out how to encourage others in that process. So I very much appreciate this opportunity as one of those examples, and definitely inspired to keep striving for more examples like this. as we uplift each other. The connectedness of human life and cherishing that and valuing each other really has come to the forefront for me during this response. So hopefully we'll all be better off in the long run as a result, when we won't take the ability to connect for granted.
Exactly. Well, it's been great to connect virtually. I too miss you in person.
Yes.
And there will be that day we can all look forward to.
Indeed.
But again, all my thanks, Nicole, to you and your team, and to you personally for inspiring us and sharing your story, being a little vulnerable and having huge impact. So thank you so much.
Thank
And
you.
everybody, I just want to remind you, our next session is with Dr. Marissa Levine. That's going to be on Wednesday, November 18th. Not a health official, but a former health official, and now member of faculty at the University of South Florida. She's fantastic and someone we both work with at ASTHO. She's going to talk about leading through crisis, the importance of mindset, self-care, and leader resilience. So really bringing the threads together from our presentations so far. So I hope you all can join us. And of course, you're invited to, Nicole and your team.
Thank you.
And thanks to everybody again for taking some time this afternoon to be with us. Please let us know what you think. We're coming to the end of our series of 5, but we might want to do some others. So if you have some ideas for other folks you'd like to hear from and learn from and be inspired by, just let us know as part of your evaluation, and you can do that right on your device today. Nicole, again, thanks so much. Say hello to everybody back in Rhode Island for me.
Will do.
Snow ASTHO's here for you and your team whenever you need.
Yes. Give my love to everyone.
You bet. Take good care.
You too.
Bye-bye.
Take care, everyone.